Excellent. Uh, Guys, I'm going to speak about the children's in PGD. So to begin with, the children's in PGD, children in PGD are the most vulnerable ones. So when we are taking care of the kids, we forget about the basic things that uh, might not be usual to them. That is about the strange environment they are going to they are in. They are surrounded by strangers. Okay, they need rapport building. Okay, so even the best of the children, no, or I would say even when they're not unwell, the rather than best of the when they're not unwell, they still need rapport building. It's not easy. When they're more unwell, they need more rapport building and more support. So playful activities, play therapist or play specialist rather are and now regular in the departments, in the bigger departments. So we are in the process of hiring a couple of them. So hopefully we should see them in near future. Uh, my biggest advice or tip for seeing children in PGD is to distraction, to engage with them, to make rapport with them. And you know what? At times, the children might be the best friend for you to look after them at that point of time. Okay, check with the PGD nurses about their concerns and listen to the parent or carer about their concerns. Okay, in ED in general, if you haven't addressed the agenda of the patient or the next of kin you haven't listened to, you haven't sorted out completely. So more so in the pediatric ED. So you have to listen to the concern to the parent. At times, their concern might not be very obvious. For example, my child doesn't look like the used to be, so it's in itself is a concern, is a complaint. So children not being at their baseline, there's something wrong and parent don't know what is wrong, and that's kind of Pandora's box to find out what is wrong exactly. But it is something you should be worried about, and this is something, if you're not getting any clue to or anywhere near to the diagnosis, might be worth discussing with the senior, because this is not easy, to begin with. So, while we do some history taking, sorry, David, here, right, if it is very much basic and rhetoric, okay, but we do history taking, source of history, witness of this story from school, nursery, any notes written by the school teacher or the school nurse. Um, Whether the presentation is timely or delayed, or is there reattendance? Okay, and worth looking at, what are the patterns of reattendance? Is it injury related reattendance? Can we call it as frequent reattendance in the past? Is there a safeguarding concern over here? uh, just professional curiosity, trying to explore the reason behind things and being non-judgmental. Looks odd to me, so I was just trying to find out what it is. Okay, sometimes, there can be cultural difference. Okay, there can be cultural aspect to it, but trying to genuinely explore is the way to go. Okay, requesting the birth history is very important, especially in the young kids. Okay, vaccination history. Since we are in the COVID times, the pandemic times, it's not unusual for me to inquire about the COVID vaccination status in the family. Uh, just to relate that, the COVID presentation in the young children can be as delayed as 6 weeks, up to 6 weeks, or maybe beyond. We don't know exactly how COVID has been behaving. So, and asking about the COVID vaccination status, about the kid and the family, if it is applicable. Social history, including the safeguarding history. It's a routine to ask, which school does your child go, or does the child goes to nursery? It's a routine to ask, does the child have any social services history, or is he or she known to social services? It's not triage nurse job, it's every clinician's job. So for examining the child, especially the young ones, the ones who do not speak for themselves, it's worth, examining top to toe, stripping to their body suit, to see if there's any other injuries over there to which hasn't been accounted for, has been missed in the past, and looking for any bruising or things like that. Especially when they present with the injuries like head injury. So in our trust, any head injury under the 1 years of age, we don't see them unless I am there on the shop floor. If I am there, and then because they need a pediatric background doctor to review the patient and discharge patient if it is. Otherwise, they are seen by the pediatric registrar directly upstairs. There is also a nurse-led discharge in our emergency department, but it excludes the under 1 year of age. Okay, you carry on with the injuries on with HENT, head, ear, and nose and throat, head, eyes, ears, and nose and throat, and then chest. When you're examining the chest, look for the work of breathing. Okay, the noise they are making, the grunting, or are they making any obvious V's that is loud, or is it conducted sound on the auscultation? Okay, is there a croupy sound of the cough that has been witnessed earlier or by the parent? Okay, so be opportunistic when you are examining the patient. So listen to the chest while they are still asleep. Okay, try and get more information about their gross motor function by seeing them how they're moving around or playing around. So, for instance, a very good example: when you see a limping child, see them walking into the consult room, and see them walking into the corridor. See how they are limping. Which side is it limping? And confirm the same with the parent. Okay, is that the side you're worried about? Similarly, you get to see a pulled elbow, so they might be holding the arm which is affected straight next to the body, and see those are the opportunistic examination techniques. So look for the peripheral versus central, and is it cold or warm? Other than these, you can always use innovative exam techniques. So, for example, you have reduced the pulled elbow. You think you have managed to feel or heard the click. So you can see if the child can take, you can offer pen or anything. The child can use it, or leave the child in the waiting area to play for some time. So that kind of gives you an idea whether the child is okay to go home. Common presentations, we have a commonest presentation in PZD is fever, okay, and we have agreed that we are going to triage fever without any concerns like sepsis, or someone who's needing the inhalers back to back, or nebs. They need to stay back in PGD. Otherwise, fever with RT with a P's less than 2, who are safe enough to go into the UCC, they will be referred to UCC. Okay. Um, the other presentation is wheeze and difficulty in breathing. Injuries are also the common presentation. Difficult one to pick up is sepsis, safeguarding concern. So what, as they say, safeguarding concern is all about curiosity, the professional curiosity. You are trying to find out, and then you go back and talk to people, talking to the PGD nurses. Did you find something suspicious or something very odd, or do you think this is concerning? So having those conversation behind and the scene, but like when you go and see the patient, you read through the triage. If you're concerned, you always talk to the triage nurse who had triaged the patient, and even afterwards, you can always discuss with the senior or the PGD nurses that this is what we are worried about. So if you're concerned about a regarding the safeguarding of a patient, you have to do a safeguarding referral. So you have to call the social services from our end in the emergency department, and you have to wait for their advice. And if they advise to admit the patient locally, then you have to admit the patient locally under the PT. Moving on to the next, let's see the presentation. So fever. Fever common is RT, including tonsillitis, okay, and or plus minus ear infection. Do we give antibiotics on a regular for the RT? Guys, any one of you can answer this question, please.
No.
So how would you decide whether to give antibiotics or not?
Based on we in GP land we use the center criteria or fever pain criteria, or if it is if we are suspecting streptococcal infection.
Sorry, I didn't know who was that. Is it Shumai? Yeah. So I mean, do you guys apply those criteria to certain age group or for all of them?
We just use it for all of them, but not for like less than 3 months or less than 3 months. No.
Is it validated for that young children? Have you looked into it?
No, I don't think so. It's validated, but Yeah.
So anything less than a 3 year, the common cause of tonsillitis is viral tonsillitis. Okay. Uh, Obviously they can have a whitish cover and whatever you can think that is it is pus like or whatever you can think. It's not uncommon in the viral tonsillitis to have it, especially in Epstein-Barr virus, ABV. So these two scales that we are talking about, pain fever scale, and the other one is the centaur, both are validated for kids 3 years and older. Okay. So especially when you're trying to prescribe antibiotics so to young children up to the age of 4 or 5, think twice whether this is just a viral tonsillitis or could be just or is it actually a bacterial tonsillitis. Okay. uh, do we know why do we try and avoid prescribing antibiotics for viral tonsillitis? So,
Sorry, I didn't get that.
we try to avoid antibiotics, oral antibiotics, in case of viral tonsillitis, simply because kids can have reaction to that, and they can have really bad skin reaction to that. They develop a rash because of the antibiotics at times, especially if it is Epstein-Barr virus infection. Moving on, ear infection. Similarly, on ear infection, if it is unilateral, you do not have to prescribe antibiotics for every ear infection. There are set guidelines in which include, if it is a bilateral ear infection or less than 2 years of age, you will have to prescribe the antibiotics. At time, delayed prescription antibiotics is more suitable. Chest infection, we don't have to do chest x-ray for every suspected chest infection. We can just prescribe oral antibiotics. UTI, so there's a nice guidance for UTI to see when the culture and the microscopy is required. So there's in the nice guidance, there's a nice table in there which categorizes the patient into the 3 age group. So I think it's less than 3 months, 3 months to 3 years, and more than 3 years. So and where you need to see which one needs to be sent for the culture, and which needs to be a delayed antibiotics prescription, or which needs to be immediate antibiotics. Okay. Other causes of fever, this could be meningitis, meningococcal sepsis, encephalitis, and septic arthritis, discitis. Discitis is very rare. Okay, I have seen only one child as of now. That was 18-month-old, fever with sudden onset, stopped mobilizing, but there was no problem with the hips and the knees and the limbs. And we had MRI to begin with. MRI wasn't really suggestive, and subsequently when we did another repeat MRI, it showed discitis. So one of the rare presentation. The rare other causes would be Kawasaki disease and the Pim's tears. Has anyone seen Pim's tears as yet? So we have recent Pim's tears in our hospital when there was a I think 13-year-old or 15-year-old girl has presented with abdominal pain. She looked quite unwell, and she literally was filling all the boxes and dehydrated, had a 6 weeks old COVID diagnosis, and she presented quite unwell because of the abdominal pain and was not able to keep things down. We'll talk about Pim's tears in a bit. Okay, so there's a nice traffic law which actually has categorized the patients and their observation and their systems examination, and how they are looking or active or activity based into red, amber, and green. Any patient who are green can safely go back home. Any patient who are an amber needs to be senior discussed, and any patient before we can think of discharging the patient. But any patient who are in red certainly need to be looked after immediately. So one of the group over here is age less than 3 months with temperature more than 38 degrees Celsius. Most of the time, these age group are usually escalated to sepsis, especially unvaccinated child, infant. If an infant is like 4 weeks or 8 weeks and unvaccinated and have a just one-off temperature of 38, they need to be escalated as sepsis. Okay. if there is any concern, always get in touch with the senior. I'm sure all the sepsis in the pediatric sepsis are being senior reviewed, and most of the time is escalated in liaison with the senior. So again, we can escalate or de-escalate as required. If there's a child who does look very unwell, especially because they are presenting early on and they're crying, they can be cranky, not settling down, and we think they are quite unwell, and we are escalating as sepsis, and gradually when we given some Calpol and they're getting better, and we decide that no, it looks absolutely fine, there's nothing concern about, and especially if you have done the gas and you agree that this is not sepsis, and you agree with the PGD nurse and the other seniors, so you can de-escalate as well. So consider research-based care, especially in the red category area patients, and try and look into team-based care, because you know what, children can be very challenging and demanding. So we might not be able to look after them, especially when they are very unwell early on, to be able to provide the care and just one-to-one, where one doctor, one PGD nurse would be sufficient. It might not be so. So it's always good to look into that. Do we need someone else over here? We recently had two sick twins over here with bronchiolitis with 80% or 79% of desaturation on air. We actually have to use two recess bay in there. We have to split the two teams together. I have to fast believe the PEDS team to come down. And in the meanwhile, while they were coming down, we were trying to split the ED team, and gradually they handed over the ED team handed over the pediatric team. And once we have sorted everything, we both the patients were started on high flow gas, antibiotics, everything done. We decided that one of the PEDS registrar can babysit both the patients in the ED research for the high flow oxygen and the management of the patient over there. So try to think: is it appropriate to give the high acuity patient just one-to-one care, or does it need a team-based care? So it's important to think about that. Again, thinking sepsis. Okay, there's very interesting paper recently released in Lancet about the study which was done nationally, particularly in children. Okay, so the PIC study, I'm sure if and Hira and you might have heard about this when you were working in Stokes and the other places. So they were looking at the guidelines, because the idea was, are we bleeding too many patients just for the sake of non-blanching rash? And they actually came up with the guidelines to see which one needs we can safely observe, or which we can safely send back home. So I mean, it's a nice way of looking at how we are treating the patient. So and so basically they are looking at the end result was to treat the patient appropriately for meningococcal sepsis, and this is the guidelines from Royal London Hospital. Okay, they have come to the conclusion that the Royal London has one of the most appropriate guidelines, where they have used Nottingham guidelines and they have used Leicester guidelines, I think, than the two other guidelines they have used to review the patients. Okay, so the idea is to look into non-blanching rash. Are they actually sick child, very sick child with non-blanching rash? Because if they are very sick child with non-blanching rash, we really have to escalate right from the beginning. Or is this a non-blanching rash in happy-looking, otherwise happy-looking child? Okay, in which case, sorry. In which case we might have to consider doing the bloods and not escalating it to everything. So example, henoch-Schönlein purpura. They usually, IgA mediated vasculitis, and they might have palpable purpura, arthritis or arthralgia in the presentation, along with abdominal pain. One of the things to worry about is they can have a tummy ache because of intussusception. So if the child looks quite unwell or crying persistently and clenching the tummy, then it's worth getting admitted and trying to get them across to the surgical unit plus minus ultrasound immediately. to see if this is actually intussusception. Okay, otherwise they can be a well-looking child. We just have to make sure they do not have thrombocytopenia, they do not have IgA nephropathy, renal AKI. Okay, so urine dip plus minus plus full blood count and the UNEs should suffice. The other one is a Kawasaki disease. It's not a common presentation. However, any fever lasting 5 or more days should be investigated for this. Okay. Previously they used to say a fever for lasting 5 or more days, along with four of the other 5 symptoms. Nowadays it has been recognized we don't need 4 of the 5 symptoms. Rather, there's so many atypical Kawasaki disease that we have had. We have realized that a lot of them are being missed for the 4 clinical signs. So if you think this could be, then get a senior review, get a pediatric input over there, and getting the bloods might be the best thing to do on these patients, because the complication is far too much to just missing on it. So the signs might be there's a nice mnemonic so for the temper. So it says persistent high fever, erythema, red hands, and feet with swelling. Okay, mouth, there could be dry, sore mouth, cracked lips. So cracked lips and strawberry tongue can be there. So eyes, there could be non-purulent conjunctivitis. There could be a rash, any polymorphous rash. Okay, and they usually have unilateral swollen lymph nodes on one side. They usually measure 1.5 centimeters. Basically, it's big enough to be noticed easily. And the other signs could be, there could be peeling of skins and toes. Okay, they are very late signs. So if you look at the nail changes and desquamation, they are a bit late to be noticed. So we are trying to see if we can pick up the patients early on, trying to avoid the aneurysm, which is heart vessels aneurysm can develop. The other thing that you'd see is thrombocytosis, which is very early finding in the Kawasaki disease. And one of the remarkable change on the full blood counts. Related to this is, the PIMS-TS, pediatric multisystem inflammatory syndrome, which is temporarily related to SARS-CoV-2 infection or exposure. So usually the clinical features are persistent fever more than 39 degrees Celsius. This criteria has been picked up from the Evelina Hospital in London. If you see, there's no set number of days, but WHO has included 3 days. It doesn't have to be 5 days. Okay, lethargy, myalgia, abdominal symptoms, pain, diarrhea, and vomiting. Sometimes abdominal pain can be the only presenting symptoms, to the extent that Evelina has published a paper in 2021 where they have a case series of patients presenting with abdominal pain and the symptoms and signs suggestive of appendicitis, and they ended up having a negative appendectomy. So suddenly the negative appendectomy rate has gone up, and they started realizing that all those patients never warranted appendectomy in the first place. So they have published a nice paper regarding that. So consider that. So the last patient that I had for PIMS-TS, I actually was convinced this is mostly PIMS-TS, and did mention that although the signs look like appendicitis, it's unlikely that she's appendicitis. But it might be worth considering PIMS-TS. And there was a to and fro within the inpatient teams between the surgery and the rheumatology, but they were not convinced this is appendicitis, and they were not convinced this is PIMS-TS. So it can be a tricky decision to make. You can also see, rash, conjunctivitis. Okay. Hypotension, wide pulse pressure, tachycardia, plus minus shock is a late sign. So hypotension, wide pulse pressure is a very sensitive sign. So tachycardia is more sensitive than the wide pulse pressure. Lab findings: hyponatremia, raised ferritin, fibrinogen, D-dimer, and renal dysfunction. Raised CRP and raised troponin with BNP can be noted. Lymphopenia, the striking feature of all the COVID patients, can be present along with neutrophilia. Platelets initially low or can be normal. There has been, two types of PIMS tears with similarities of either Kawasaki syndrome or shock, or it could be similar in presentation to toxic shock syndrome. Nevertheless, the treatment more or less stays the same. You still have to escalate them as sepsis. The immunoglobulin and comes in as inpatient management, not in the ED management. In the ED, you have to give guarded fluids. Okay, so you can start with the 10 mils per kg and then see if you need further fluid boluses. You can start with the maintenance fluid if possible. Otherwise, most of the kids will go upstairs in PAU and then they can start with the maintenance fluid. But make sure they get the IV access, they get the cultures drawn, including the blood culture. They get the chest X-ray and get the IV antibiotics on board. Okay. Cardiac manifestation: there has been cases where pancarditis has been seen. Okay. Other dysfunction has been seen as well. There has been global cardiac function has been deranged. Okay. The course is unpredictable with rapid deterioration. Has been observed in some patients. Febrile seizure. So 6 months to 6 years, not uncommon in this age group, especially when they go a very high temperature. And then recently there has been nice guidelines saying that we don't have to try and bring the temperature down unless the child is distressed. We do not give the antipyretic regularly. Simple febrile convulsion, isolated generalized tonic-clonic seizure lasting less than 15 minutes. Do not recur within 24 hours or within the same febrile illness, with complete recovery within the first hour. However, if they have partial focal seizure, duration more than 15 minutes, recurrence within 24 hours, or within the same febrile illness, or incomplete recovery within 1 hour, they're usually stratified as complex febrile seizures. Guys, are you with me?
Yep.
Yes.
Sorry, it's a bit monotonous and boring, especially when there's no face-to-face. Feel free to interrupt and ask me anything if you want to, please. Okay. Bronchiolitis, we have a bronchiolitis pathway over here locally, which has been agreed for the in green, amber, and red. So all those pathways are there on the Ask Earl, so under the pediatric guidelines column. So the idea is to get the red bronchiolitis patients straight to research to be seen by us and fast leave the pediatric reg to join us. Amber can be seen in PAU provided if the PGD triage nurse is concerned that this baby, although Amber looks unwell, needs a senior eyeball. Then we have to actually see those patients to see if they're fit to be getting unwell soon, and they would be better off to be seen in recess or in the PGD, and then go upstairs eventually. In that case, we still have to call the pediatrics to come down and join us. So bronchiolitis, they can be wheezy, okay. They can be craps, okay, and they can be, if they're working very hard, they can be grunting, okay. At times you can hear the stridor. So usual story is basically snuffly nose and chesty cough, poor feeding, vomiting, plus minus fever. There can be patients who are without fever, increased work of breathing. So the usual sign is tracheal tug, okay, and the chest recessions, subcostal recession. But very young babies might not be able to show those things very obviously. But one thing can be striking with the increased work of breathing is head bobbing. Okay, so see if there's any head bobbing, cyanosis or apnea. These are now high risk features. Okay. Severe disease can happen to kids who have pre-existing lung disease, okay, chronic lung disease of newborn. immunocompromised congenital heart disease, or less than 6 weeks premature, more than less than 35 weeks. Okay. Neuromuscular disease patients are high risk as well. We don't give inhalers or nebulizations at all. We don't give salbutamol or Atrovent at all. However, if you look at the guidance by the BTS, it clearly mentions about the transition period between the 1 year and the 2 years, where the bronchiolitis can be transitioning into the viral V's, or there is a first presentation, you're not sure whether this is viral V's or bronchiolitis. It might be worth giving a trial of salbutamol to see if the child is getting any better, or no response, or getting worse. So that can be tried. Has any of the Reg done that before?
Can you repeat the question again?
Have you guys done it before, like giving a trial of salbutamol in a 1 to 2 years old child where you're not sure this is bronchiolitis or this is viral V's?
No.
No, I don't prefer to.
Okay.
So
Yeah, go ahead.
I just wanted to add, if a child is less than 5 years old, we can, if we are not sure that is it a viral vase or no, we can give a shot, a trial of SABA. But if not, if this isn't controlling the symptoms, then we can give a 8 weeks trials of trial of moderate dose of steroid as well.
Are you talking about acute presentation, or are you talking about long-term management?
With the acute presentation, we can give a trial of SABA.
So
as per the NICE guidelines. Yeah.
So I mean, in this scenario where the child is, so bronchiolitis in the age group of less than 1 is common. There might be a very rare instance or circumstance where we have to try, and this will come mostly from the pre-hospital, where the patient has been given nebulization by the ambulance crew, because their pathway runs like that. Okay. So and we can't really make change in the this is something to be done by their end. However, in the hospital, in emergency department, we do not give any inhalers or nebulization to less than 1 year of age, especially when we are suspecting bronchiolitis, because bronchiolitis is more common in this age group, and they don't have beta receptors developed for salbutamol to act. So there's no point giving salbutamol or anything in that age group. They basically need support with the oxygen. They need support with the feeding. They need support with if they are too unwell to bottle feed or breastfeed, then we have to give them NG feed, or at times IV fluids if they are getting on the high flow oxygen. Okay, so basically symptomatic support, feeding support, nasal saline plus minus suction. Suction, we don't do suction, just cleaning the nose, wiping is enough. Suctioning is mostly done in the PICU when they're admitted, and especially when we are supposed to send any suction for the aspirate for the checking whether they are bronchiolitis to see which virus is it. Important thing in bronchiolitis kids, because they are very young kids, they're infants, and they can deteriorate quite soon and quite significantly. So consider escalation if they're looking poorly at the time of presentation. So as I said, there are red, amber, and green pathway. Okay, so these are the red signs. So it's on our scale to have a look. If saturation less than 92%, this is a red pathway for the patients. Okay, unable to rouse or wakes only with prolonged stimulation, no response to social cues, weak or continuous cry, appears ill to health professionals. Okay, if they're pale, mottled, ashen blue, cyanotic lips and tongues. Okay, there has been no mention of Pew's score, because Pew's is not predictive. However, they have mentioned the nasal flaring over here, chest recession over here, less than 50% of fluid intake, or 2-3 feeds, or 24 hours. Okay, significantly reduced urine output. If you have no urine output for last 12 hours, you would be really worried about that. So urgent action, immediate pediatric assessment. So you can start the patient in rhesus and get the patient in oxygen. Okay, and the other thing to mention is they get 2/3 of fluids, or either oral, NG, or IV. Okay, step up high flow oxygen therapy or maybe CPAP. We usually start high flow oxygen therapy down here in ED, in the PGD resus. Okay, we haven't started CPAP. They usually go upstairs and get transferred to CPAP, but in rare circumstances we might have to start with the CPAP. Discharge criteria for bronchiolitis. We do not discharge any bronchiolitis patient from the PGD. We usually, such patients will end up in the UCC, where the GPs will see the patient and discharge the patients, or else if they are concerned, they will refer directly to the PEDS. Viral VEs usually toddler more than a year, or preschool children less than 5 years. Sometimes to the more than 5 years of age, because they're yet to be diagnosed or labeled as asthmatic. Inhalers with spacer device is a treatment of choice. Life-threatening gets the NEBs. Otherwise, we try to give inhalers. We can give back-to-back inhalers, 10 puffs each. When we are giving NEBs, we try and add the Atrovent to each one of them, rather than just giving one salbutamol and Atrovent. So it's usually, especially when they're quite unwell, it's worth giving them salbutamol plus Atrovent back-to-back, 3 of them. The steroids over here, if we have viral Vs, we are treating viral Vs, we try and give dexamethasone. If they are non-asthmatic, we prefer prednisolone. The inpatient pediatric team prefer prednisolone. Both the BTS guidance on the Vs and the asthma, and the BTS guidance on the bronchiolitis, the bronchiolitis pathway, as well as inpatient guidelines for the asthma management or Vs management, is there on the pediatric ASK guidelines. So it's quite blurry. Basically, it's about differentiation between moderate asthma, acute severe asthma, and life-threatening asthma. I just wanted to make a point that less than 92% of saturation can still be acute severe asthma rather than life-threatening asthma in children, and in contrast to adult asthma. Okay, so we can safely treat acute severe up to acute severe asthma with back-to-back inhalers rather than giving them nebulization. The reason I say back-to-back inhalers is because there are a lot of kids who get the timely back-to-back inhalers right away, and nebulization needs a room and everything that kind of get compromised, and time taking. If there is a sick patient who's life-threatening asthma with silent chest, poor respiratory effort, agitation, confusion, sinuses, yes, they need to go to resus and give them back-to-back nebs, and give them everything like salbutamol, Atrovent, 3 back-to-back. Give them if they're well enough to take orally, try and give them dexamethasone. Otherwise, you might have to give IV hydrocortisone. If they're still not recovering, you can do either another bus therapy, or you can do magnesium sulfate. In the meanwhile, you can ask the pediatric team to come down to see this patient as well. Okay, do you guys have any question over here? So if you look at the BTS guidance, okay, they have categorically mentioned, you can repeat bronchodilators 20 to 30 minutes, 20 to 30 minutes, okay, and they have mentioned about why beta 2 bronchodilator with aprotropium via nebulizer. Okay, so you can repeat both of them every 20 to 30 minutes. The idea is to give back-to-back 3 of them within the first hour, okay, if they're too unwell. Okay, but if you're doing the acute severe one, so you can just do back-to-back inhalers. You don't have to give nebs. Okay, in case of non-responding, I've mentioned already. Okay, for the regs, it's worth trying to think if this patient will get worse, so we need to think of IV access. For the SHOs, we'll try and get the senior early on. So talking about the BTS asthma Vs, okay, under 2 years of age, between the 1 and 2 years, the transition phase, okay. Uh, you know what, it's worth giving a trial of salbutamol. Give trial of beta 2 bronchodilator to see if they improve or not. If they're not improving, then they might be just bronchiolitis, or if they're improving, then you can either carry on doing the burst therapy, or they're better and you don't think their burst therapy is warranted, you might consider dexamethasone for, or you might not consider dexamethasone if they're not that unwell. Okay, DKA, there is a DKA calculator. It's again on the online. It works on Chrome better. There has been recent change. It hasn't been that recent. It's been 2015, 2019 DKA guidance update, 2019 or 2020, I think. It's been a bit of time. So they have introduced, the mild, moderate, and severe DKA. So 7.2 to 7.29 bicarb less than 15 is mild, 7.1 to 7.19 and bicarb less than 10 is moderate, and severe is less than 7.1 and or less than 5 bicarb is severe. So if you click on the DKA calculator, it will give you the recommended. So go on the Google Chrome, go on the Ask-Curl, and you will find the DKA calculator in there. Just get the VBG straight away on this patient. There's something called euglycemic DKA, which can happen in children and pregnant ladies. Okay, so think about keep that in your back of your mind. There has been a presentation with 9-year-old with tummy pain, and the BM was found high when she got treated. I had a patient who was I think 2.5 or 3 years old, who was just being quiet and not really being themselves. She was just tachypnic, and she won't talk, she won't interact. We checked the BM, her BM was really high, and she was severe diabetic acidotic. Okay, so just atypical presentation can be there as well. So talking about the afebrile seizure, we follow the APLS guidelines. Okay, so two lots of benzodiazepine, and then you can consider paraldehyde in between. Okay, if it is available, and consider to load the patient. There has been recent drive to go on Keppra rather than phenytoin, because phenytoin takes longer. It takes 20 to 30 minutes to be given. Keppra can be given in 5 minutes. The recent update is that in the new APLS guidance, they're going to introduce Keppra instead of phenytoin. So which is yet to be published, but as a consultant, I usually try to prefer Keppra if we have Keppra, but you will stick to the guidance at the moment, which is APLS, which says phenytoin. If you have any concern, try and seek help from the consultant in such patients. Important thing to remember, if you do not have IV access and you think it is difficult to get the IV access, just get the IV access straight away. If the sick child is there and you think getting IV access is difficult, get the IV access. A to E assessment, okay, and you manage simultaneously. First, if they have first fit, they need to be admitted and they need to be, followed up in the first fit clinic. Okay, if they are non-epileptic, they again need to be admitted if this is for long. Okay, if there's advanced so if there is advanced care plan, they have to be managed accordingly. Make sure you do not forget the sugar to check. Okay, injuries, major trauma, get the senior involved. Think about pediatric trauma team activation. Presentation, timely or delayed, consider safeguarding concern. Professional curiosity. Patient safety, recess or cubicle. Are the patients safe to be managed in the cubicle? Primary, secondary, tertiary. Victims in the polytrauma peds. Are they unwell? Okay. Is there any death in the trauma that the kid was involved? Okay. And the other thing is to consider debriefing, because if we are seeing 2 unwell patients, so we had 2 child deaths and our dead children, infants brought to ED. where we had held the core debriefing after a month to see what we can learn from that. So hot debrief right after the event and cold debrief after a while. If they were high fidelity or high acuity presentation. Head injuries, nice head injury guidance to follow. Mechanism of injury, please consider what was a mechanism of injury. A scary sight for parents. They can be drowsy, floppy, loss of consciousness, irregular breathing, floppy, pale. So this has happened with me recently where my toddler who had a head injury, he fell backwards on a carpeted floor, hitting his occiput, and my 10-year-old daughter got him down saying that, you know what, he looks quite different and pale. I don't know what has happened. And he was really floppy, and I really got scared. I called 999. I, being a PEM consultant, I called 999, and then they actually handled the call and got me in 2 blue light ambulances, and then we have to put him on the sofa, and then he gradually, so he had irregular breathing, he was pale and floppy. Okay, and then when he was put down on sofa, he started coming around and became more pinkish. Okay, we have to take him to A&E over there, and then we have to observe the kid and observe him over there. So what I'm trying to imply over here, it's a very, very distressful sight, okay, for the parent. Okay, since you haven't witnessed it and the parent have witnessed it firsthand, they know how bad it is. However, they might still not fit into the criteria of the CT scan. So it's important to go through that, and getting a senior involvement early on, whether this patient needs a CT scan or we can avoid a CT scan. Avoiding a CT scan in children can be tricky because you know what, the criteria is so cut to cut that you might feel it's difficult to avoid the CT scan. So that is why it's a senior decision maker at a consultant level can help you in that regard. It has been agreed with the PEDS team, if they think the baby is too unwell or the head injury hasn't been CT scanned, they can CT scan upstairs. It's again the same thing, escalation, de-escalation. Anyone who's worried about the kid can escalate, and anyone who's not worried about the kid and they think the kid is okay can de-escalate at a senior level. Injuries to the limb. Sorry guys, 5 more minutes and I'll just finish. Of injuries to the limb, look for the long bone fractures, whether they are age appropriate or not. Are you considering a non-accidental injury or accidental injury? Mechanism of injury, try to join the dots, do the mechanism, corroborate with the injuries. Okay, supracondylar fractures, is it age appropriate presentation or is it not age appropriate presentation? Femur tifid fractures in infants. Okay, toddler fracture versus trampoline fracture. These are toddler fractures, when they twist around, running around, they end up having a distal 1/3 and a tif fracture. Tib fracture, not fit. And trampoline fracture is the proximal 1/3 fracture of the tib again. Okay. Limping child, atraumatic, traumatic, limping child. There's a limping child pathway on our scale, so worth having a look. Okay. Just as a dictum, just remember, babies who don't cruise shouldn't be bruising. So again, any mechanism of injury, time of injury, any delay in presentation, what was the reason for delay in presentation? It's absolutely fine that the baby didn't look too unwell, and mom was worried, but however, she has got 2 children on board, so she called up dad saying that I'm going to take this child to hospital. Do you mind to come in? And the dad came in a bit late from the work, but mum did try to come in as soon as possible. So trying to have professional curiosity, trying to find the story, the context of the delayed presentation. Was it witnessed, unwitnessed? If it is unwitnessed, the likelihood of non-accidental injury cannot be ruled out. Corroboration between the story and mechanism, low threshold for considering, if you're considering NAI, especially when the safety of the child is at stake. Look for the pattern of bruising. Okay, are there multiple bruising on a child who isn't cruising or hasn't started walking? Then it's concerning, whether it is a medical reason or a non-medical reason or non-accidental injury. So for sick children, if you're preparing for resuscitation, make sure you do wet flag. We have, the PGD nurses do a weight estimation using the formula, and then they print out the kid's calculator of all the drugs to look into it, and they pre-print it. It's a very scary situation. Try and do a team-based approach led by the senior. Okay, for Hira and Dave, you will have good opportunities at leading the team over here. When I'm around, I don't mind you guys leading on the such sick children. Okay, so feel free when you want to. Ms. Ba, do you mind if I do this? And if you guys want team leadership, mini kex or CBD, whatever, please come and find me. Systemic approach, A to any approach, wet flag, APLS protocol is usually followed. In sick children, respiratory arrest is more common than cardiac arrest, okay, for obvious reason. Kids' heart is still very good and strong and functional unless they have got congenital heart disease, okay. A rate limiting step is basically IV access. So if you think this is delaying your management, get the IO access. We got the easy gun. History examination and differentials. Okay, so it might not be a vertical or the sequence of the same, but sometimes managing and then examining and then getting some history and then making some differential, or starting with differentials at times, it's a bit challenging situation like adult resus patients, but you can stop allocating jobs to people, because in the peds you might get the peds team straight away. So asking the peds SHO to get more story, listening to the handover together rather than one by one. And when you debrief the team, you can always think loud what you're thinking and listen to the others concerned. Planning for further investigation management. So there's a kids referral pathway, which the pediatric team usually do. Okay, so trying to think of that early on to see where we're heading. Or is this patient going to come in locally, or is this patient going to go to PICU? So in the sick infants and neonates, think of 5 big things: infection, sepsis, okay. Hypoglycemia is common in sick babies, so they need support with the sugar. Is this metabolic hypoglycemia? So again, we can send ammonia in addition to BM, lactate, and ketones. So there's I think it's a green bottle, and we have started doing this test locally as well. So we have to get the we have to send it with the ice cubes immediately. So NAI is one of the differentials, so make sure you examine the patient without clothes. Okay, surgical, they failed to pass meconium 24 to 48 hours. Other differential can be Hirschsprung disease, neck, and pyloric stenosis. Fluid management is important in all these children. Okay. Pitfall, there's a vaccine-induced fever, men be around 6 hours. So it's important when the kids have the first vaccination and they present with the fever, ask them when did the fever start. Okay, is it related to MENB or is it related to query sepsis? Okay, so it's important that you ask that question. Any questions, guys? Hello?
Thank you so much. Thank you so much.
I'm really sorry I have to extend my time beyond 6 minutes. Feel free to come and get me regarding case-based discussion, mini kex, or leading team leading opportunities for the regs if you guys are interested. With the pediatric patient, I'm more than happy to help you guys and see through. Okay. Anyone interested in research can also talk to me. I am running a wrong start study in the department at the moment, and we are doing quality improvement project of pain in children. If any of the regs are waiting or any of the SHOs are looking for the quality improvement projects, they can come and get me. Thank you, everyone. You have a wonderful stay in the ED. Well, then good luck. Thank you
so much, Dr.
Thank
you.
Bye.
Thank you.